Now we begin a nice, easy section on antidepressant medications. The schematic in the book points out the different mechanisms of action of many of the medications you may see on the boards. As we work through the rest of the sections on the next 2 pages, keep referring back to this picture as your guide to understanding how to think through the similar but distinct mechanisms of each of these drugs. Now, the goal of antidepressants the whole way through is to increase the concentration of norepinephrine and serotonin in the synaptic cleft. Remember from earlier chapters when we discussed patterns of neurotransmitter changes in different psychiatric illnesses, almost all neurotransmitter are decreased or depressed, if you like, in concentration in depression. So, increasing their concentration is the goal of therapy. And generally speaking, the 2 different types of neurons that are affected by antidepressant medications are the noradrenergic neurons and serotonergic neurons. Let's start by looking at the serotonergic neuron. As neurotransmitter launch from the presynaptic neuron to the receptor on the postsynaptic neuron, so here's the neurotransmitters, and they're going and binding to the postsynaptic receptor. They can either bind to the receptor or itself, or they may get taken up by the presynaptic neuron again to be reused or metabolized. Now, to increase the concentration of serotonin in the cleft, medications like SSRIs block serotonin reuptake. So you see here SSRIs block that uptake by the serotonin transporter SCRT-SERT. And this causes increased concentration of serotonin in the synaptic cleft, and the postsynaptic neuron remains activated. SSRIs, or selective serotonin reuptake inhibitors, include fluoxetine, paroxetine, sertraline, and citalopram. The mnemonic that those of us on the first aid team came up with is flashbacks paralyze senior citizens, a reference to their use in PTSD. So these SSRIs are actually used in PTSD, and so that fits with the mnemonic flashbacks paralyze senior citizens. So those are your SSRIs. Their clinical use involves depression, generalized anxiety disorder, panic disorder, OCD, bulimia, social phobias, and as we said, PTSD. In terms of toxicity, SSRIs are considered less toxic than TCAs, the tricyclic antidepressants. But the predominant toxicities to know about are GI distress, sexual dysfunction, which is pretty common and is often a reason patients want to stop taking SSRIs. And a very important side effect to know about is serotonin syndrome. Basically, if a patient taking SSRIs also incidentally takes a medication that increases serotonin concentrations, like for example MAO inhibitor, they will get serotonin syndrome. Think of it as neurotransmitter overload, because they're taking the SSRI, which blocks serotonin reuptake, and they have an MAO inhibitor, which blocks metabolism of serotonin. They get serotonin overload, and it presents with hyperthermia, confusion, myoclonus, cardiovascular collapse, flushing, diarrhea, and seizures. Now, the first half of these symptoms may sound pretty familiar, particularly the hyperthermia and muscle rigidity, also known as myoclonus. And what does that sound like? You guessed it, it sounds like neuroleptic malignant syndrome. But what will clue you off to serotonin syndrome is the vasodilatory effects, seen here as flushing, And that flushing and also the cardiovascular collapse is the clue for serotonin syndrome. Now, the treatment is prompt administration of cyproheptadine. And what do you think this does? It is a serotonin receptor antagonist, specifically 5-HT2. Now, can you recall another 5-HT2 receptor antagonist that we recently talked about? That's right, the atypical antipsychotics. In fact, severe cases of serotonin syndrome can be treated with olanzapine also. One last relevant fact about SSRIs goes like this. Let me give you a sample question. There's a 22-year-old female who presents with multiple episodes of depressed mood, difficulty concentrating, sleep disturbances, etc., etc. And 1 week ago you prescribed her fluoxetine. Sounds like depression, right? She comes back to your office saying her mood has not changed. Then the answer choices will ask you to say, what should you do next? And most will suggest either switching medications or adding on another medication. But then choice E on the boards will say something like, provide reassurance and ask her to come back in 3 to 7 weeks. So what's the right thing to do here? The correct thing to do is actually answer choice E, reassurance and ask her to come back in 3 to 7 weeks. And the reason is because it often takes that amount of time for patients to notice any appreciable difference in their mood. So, what's the lesson of this story? SSRIs take time to cause an appreciable difference in mood. So, wait 3 to 7 weeks for effects. That is the lesson of that story. Now let's look at the noradrenergic neuron. Now there's a similar analogy to everything we discussed with the serotonergic neuron. In this case, norepinephrine, seen here, can bind to its receptor on the postsynaptic neuron or get taken up into the presynaptic neuron, where it can be reused or metabolized. So to increase the concentration of norepinephrine in the cleft, medications like SNRIs can block the transporter, the norepinephrine transporter, or NET. And this will cause increased concentration of norepinephrine in the synaptic cleft, which then causes the postsynaptic neuron to remain activated. SNRIs are a newer class of drugs, and the two common ones on the market are venlafaxine and duloxetine. It's important to note for SNRIs that they actually inhibit the reuptake of both serotonin and norepinephrine. Their clinical uses are primarily for depression, but venlafaxine can also be used for patients with generalized anxiety disorder and panic disorder. And duloxetine can also be used for patients with diabetic peripheral neuropathy. So toxicities, they don't have as many side effects related to non-serotonin or norepinephrine receptors, like for example the anticholinergic or alpha-blocking side effects that are seen with tricyclic antidepressants. But the most common side effect to know about is increased blood pressure. So patients with a history of poorly controlled hypertension would likely not be good candidates for this therapy. Other non-specific side effects include stimulant effects, sedation, and nausea. That may have felt like a lot of information, but make sure to keep going back to that diagram in your book to keep the mechanisms of all these drugs straight. Keep in mind that the names of the drug classes often give you a clue as to how they function, so if you understand the name, you can easily remember the mechanism. Now let's focus on some of the tricyclic antidepressants. While these aren't necessarily the first line, they're some of the oldest and best studied drugs in psychiatry. And because they're so old, and there's so many of them, they don't really follow a great naming convention. So you have to memorize them. And the drugs that we're going to study include amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, doxepin, and amoxapine. They're a bit tough to remember, but I like to remember that they all contain either it and then ene, like amitriptyline or nortriptyline, ipene again, or imipramine, ipene again, or ox-in, like doxepin. So the mechanism of action is that TCAs block the reuptake of both norepinephrine and serotonin, like we saw in the previous diagrams. Their clinical uses are relatively broad, starting off, of course, with major depression, but they can go all the way to even things like fibromyalgia. Now, specific ones also have certain additional clinical indications. Now, do you remember which one we said can be used to treat OCD earlier in the chapter? Right, it's clomipramine. Additionally, imipramine can be used to treat bedwetting. That's an interesting one to keep in mind. Imipramine for bedwetting. And during what stage of sleep does bedwetting occur? If you remember, from the behavioral science chapter, it occurs during stage 3, sleep. Now let's look at the toxicities. While these drugs are considered to be effective for their clinical indications, the major drawback to their use is their pretty awful side effect profile, and they include sedation, alpha blocking effects, anticholinergic effects. Now the third generation TCAs like amitriptyline have worse anticholinergic effects than the second generation ones such as nortriptyline. While anticholinergic side effects may simply show up as tachycardia or urinary retention, which may be more benign, elderly patients may actually suffer from hallucinations. So it's particularly important to use second generations for this reason. With overdose, you can get the tri-Cs, which include convulsion, coma, and cardiotoxicity in the form of arrhythmias. You can also get hypoventilation. The tri-Cs, as well as the other side effects of this class, show up a lot on test questions since they're fairly unique among psych drugs, so memorizing them is high yield. TCA overdose should be treated with sodium bicarbonate to alkalinize the plasma and help neutralize the active byproducts of TCAs. Okay, flash quiz. What are the common adverse effects of selective serotonin reuptake inhibitors? The answer is gastrointestinal upset and sexual adverse effects. Now, the common sexual adverse effects are anorgasmia and decreased libido. Remember that these sexual side effects are one of the common reasons that patients want to stop taking the medication. And also remember that SSRIs can cause serotonin syndrome, which is much more serious, but not as common.